So first of all, somatic pain and dysfunction is pretty bad thing because it greatly affects patient lives. And but besides affecting the patient life, it actually, let me share the screen. As you can see here, different countries with significant number of patients suffer from the chronic pain and dysfunction on daily basis. And we also have to consider that they already went through the different therapies. And this therapy is still not working because they're still in pain. But besides affecting quality of the life, it's also affect function of the society because usually people who have suffered the most is the more active workforce. So from that perspective, management of the chronic pain and dysfunction become not only medical but social problem. And on top of everything, if we will look at the current way of management, which requires different application of techniques or modalities applied separately or individually, while in reality it's supposed to be comprehensive rehabilitation. And if we're looking for the very simple logical thing, if we continue to have patients with chronic headaches and lower back pain and hip pain, and they're coming again with the same symptoms, something wrong with rehabilitation. So during my lecturing, I sometimes mention that the somatic medicine is bad child of the modern medicine. We have genetic medicine, immunotherapy, stem cells, but we cannot fix look like simple things. However, they are has dramatic impact on the patient lives. So if we're looking on the somatic function, normal somatic function, it relies on two equally important components, function of the soft tissue and the function of peripheral and central nervous system. And commonly accepted views that peripheral and central nervous system control function of the soft tissue, and that's true. However, the problem is much more complicated because incorrect treatment or presence of the chronic pain for some period of time start to change function of the brain itself. And in such case, it's not only traffic from the central nervous system to the soft tissue, but inappropriate function of the peripheral receptors eventually start to affect quality of life to the patient by affecting the neurotransmitters and balance, and create anxiety, depressions, which accompany by the chronic pain. But on top of everything, it activates so-called neuromatrix within the brain, and that's ability of the brain to reprint same pattern of pain and amplify already existing clinical pictures. So right now we can say that it's very complex reflex relationship between different types and layers of the soft tissue, as well as different parts of the central nervous system and the soft tissue. From that perspective, the health practitioner who work with the somatic rehabilitation has to see bigger picture and understand there is a lot of small puzzles, and only putting them together equals proper rehabilitation. So if I split all the patients with somatic pain and dysfunction in two major groups, some of them will have trauma as the beginning of the process. And this is critical aspect because patient who had trauma, which at some point triggered his lower back, he or she will forever remember that accident. And if there is no acute trauma in the previous times, then we're looking for the reflex zones formation, which are actually trigger for the somatic dysfunction. So let's look first on the soft tissue. That's basic arrangement of the soft tissue in the human body. Let's look on the posterior leg. This is the skin, subcutaneous fat, superficial fascia which covers the gastrocnemius, deep fascia which covers soleus and separate two muscle group, and then the soleus insert into the periosteum and periosteum tightly attached to the bone. So In the in the view of somatic rehabilitation, many health practitioners look on the soft tissue as a bulk. Oh, there is active trigger point there, then we need to do this, we need to do that. But in reality, soft tissue in each part of the body is actually layer cake. And if we agree on some basic principle that anatomy, physiology, and blood supply and function of the skin completely different from the same of the skeletal muscles or superficial fascia, then we need to address soft tissue on layer by layer basis. This is foundation for the proper somatic rehabilitation. When instead of working on the tissue, soft tissue and the bulk, the therapist or health practitioner uses precisely guided missiles which target each layer separately, because we have techniques and modalities which we're addressing each specific layer of the soft tissue, and combination of that therapies allow to peel off the tension and, more importantly, restore fluidity of the movements between the layers. So, as you can see here, the superficial fascia or periosteum has line of fibrotic bridges. This line of fibrotic bridges control fluidity of the movements between the layers of the tissue. When we're walking, when we're jumping, everybody moving against each other, skin against the fascia, skeletal muscles against the deep skeletal muscle against the periosteum. The constant movement of the layers give us normal range of motion. That's why restriction in the range of motions or tilt of the pelvis, all of that, as if the therapy based on addressing that, that's complete nonsense. Because technically speaking, what's happened with the joint, if it's not, of course, advanced osteoarthritis, it actually happened with the soft tissue, because adhesions which form in the fibrotic bridges will start to glue layers of the tissue together, creating actual clinical picture. So this is a visual presentation of this event. As you can see here, skin, subcutaneous fat, superficial fascia, fibrotic bridges, and superficially located skeletal muscles. So here is normal activity. You can see clearly the skeletal muscle contracts, and the contraction of skeletal muscle in significant degree depends from elasticity of fibrotic bridges. Now, as a result of trauma or inappropriate innervation of the fibrotic bridges, they start to tighten themselves and form so-called adhesions. When adhesions form between the layers, they glue layers against each other, and that creates chronic tension and spasm. Proper therapy, which formed layer by layer, address layer by layer, allow to restore the function. And that gives you elimination of somatic abnormality. That can happen only with a technique which rely on so-called lateral shift. Lateral shift allows to move tissue not in the vertical, but in the lateral medial direction, which restore mobility between the layers. Now, let's look on from that perspective. I mentioned the abnormality in the soft tissue in form of adhesion can form due to the trauma. That's true, but it can happen as a result of inappropriate innervation and reflex zones formation. So here is basic idea of the control within our body uses. Peripheral receptors located in inner organs in the soft tissue, and they constantly, and I emphasize constantly, from the first breath to the last breath, feeding spinal cord and sensory cortex with the data in the form of electric potentials called action potentials. Then they alter flow to the sensory cortex. Sensory cortex accept that as the symptoms in form of tingling, numbness, or pain. And when that happens, then sensory cortex activate motor cortex, and motor cortex create descending control, trying to help affected inner organ or soft tissue. Technically speaking, pain in the lower back, not in the lower back. pain is pure brain creation based on the data obtained from the pathologically changed peripheral receptors. That's why addressing pain as a factor is chasing our own tail. We need to see bigger picture. Technically speaking, what you see here is the analogy of the highway. From the first breath to the last breath, information travel to the brain, and from the brain through the lines of the highway, as you can see in the cross-section of peripheral of the spinal nerve. Now, I will present idea of reflex zones formation, which was developed in 1947 by Professor Kohr in the United States, but it was two German physicians, Dr. Glaser and Deliha, in Germany, who actually formulate modern concept of reflex zone formation. I will present that on example of the carpal tunnel. As you know, carpal tunnel is symptoms of discomfort on the palm, tingling, numbness, loss of thinner, muscle atrophy, and inability to perform three fingers prehension, which is foundation for our hand function. So this is, let's consider, and it's not only a matter of the carpal tunnel, it can be any abnormality within somatic. It can be plantar fasciitis, or it can be headache. Here is the body of the neuron located in the spinal cord, which originates median nerve. And median nerve goes through the hand, neck, arm, forearm, and eventually end up with the hand when you have a bunch of peripheral receptors, which report back to the neuron, to the body of the neuron, and then from there it goes to the sensory cortex. So here is the normal function. Peripheral receptors work properly and they deliver information as the electric potentials flow from the peripheral receptor to the body of the neuron. And this is normal activity. Let's say this is approximately level of anterior neck. That's where anterior scalenus muscle located. Anterior scalenus muscle is the guard of the brachial plexus. And but if anterior scalenus muscle even slightly get tight, what it does, it starts to irritate brachial plexus. In our scenario is origin of the median nerve. So here is irritation, mild irritation of the median nerve. What will happen at that time? You have bottleneck traffic. Peripheral receptors from the hand send information with normal number of signals trying to reach the brain. But anterior scalenus muscle now blocking number of signals which supposed to arrive to the patient brain, and the patient start to feel tingling on the palm or numbness. And here is the problem with the somatic rehabilitation. Because, and if the irritation of the median nerve on the neck by anterior scalenus muscle is mild, patient never ever will complain about symptoms on the neck. He will complain about symptoms at the end of innervation. And in case of median nerve, it will be the palm. So everybody treating his palm as a carpal tunnel and nerve conductor study confirmed the presence of the median nerve neuralgia. But in reality, a real trigger sits in the completely different part of the body. That's why in somatic medicine, anterior scalenus muscle has nickname silent killer, because it can produce everything from the headache and middle back pain to the arm dysfunction and even false cardiology mimicking heart attack. So right now, this is a clinical picture of anterior scalenus muscle syndrome, which is mild irritation of the median nerve on anterior neck, while the patient only present with the symptoms of the carpal tunnel, and everybody try to fix his problem, including surgical intervention. However, if there no proper therapy and the tension between the anterior scalenus muscle continues, then amount of pressure elicited changes, and now anterior scalenus muscle not irritate but compresses brachial plexus, and that gives completely different clinical picture, because now patient in screaming pain tells everyone the pain from my neck goes through my arm, forearm, and hand. At that time, it's already obvious that patient has peripheral neuropathy, and nobody will treat his his carpal tunnel anymore. But this is now thoracic outlet syndrome. So anterior scalenio muscle syndrome, which is mild irritation of peripheral nerve, and the thoracic outlet, which is compression of peripheral nerve, are two stages of the same process. But on the early stages, the reflex zones present themselves as completely different and unrelated clinical scenario. And therapists and health practitioners try to address the consequence without examining and finding or rule out other triggers. So here is uh, analogy of the carpal tunnel again. So symptoms are on the palm. Indeed, pressure within carpal tunnel by transfer carpal ligament will trigger symptoms of the carpal tunnel on the palm. There is no doubt about that. However, tension in the pronator teres below the elbow, tension in pectoralis minor, tension in anterior scalenio muscle on anterior neck, tension in posterior cervical muscles or abnormalities in the cervical disc in early stages will give exactly same clinical picture of the carpal tunnel. Only when pressure in these areas reach critical mass, then the patient brain establish cause and effect. Pain from my shoulder go to my hand, or pain from my neck go to my hand. At this point, it's obvious. But in stage of anterior scaleral muscle syndrome, which is mild irritation of median nerve, and the patient presented as a carpal tunnel and go to unnecessary surgery just because health practitioners did not rule out other triggers. And how health practitioners need to do that? They use compression tests in all this area, 1, 2, 3, 4, because each of the area has specific treatment protocol to make to free nerve from irritation and eliminate symptoms at the end of innervation. By examining to apply by applying additional pressure in this specific spot every time therapist ask or health practitioner patient if anything changes on the palm. If I'm applying Wartenburg test above the clavicle on anterior neck and patient feels symptoms down to the hand, any additional symptoms, even some pulsation, that means that anterior scalene is responsible for the clinical picture of the carpal tunnel. And then the only treatment of the trigger will eliminate the consequence. Yes, it needs to be treated on a local level, but after Wartenburg test become negative. And unfortunately, it's not a matter of the anterior scaleral muscle. Again, mild irritation of sciatic nerve by piriformis will give you plantar fasciitis. And our patients go through the inserts, through the podiatrist, and everybody treating, and an injection, and all of that. While in reality, it's mild irritation of the sciatic nerve, which triggers spasm in the plantar fascia. And it continues and continues. Chronic headache, the most debilitating cluster headache result of mild pressure on the greater occipital nerve in suboccipital space, and only the compression of the obliquus capitis superior, obliquus capitis inferior, and semispinalis capitis, and free the occipital nerve from the compression will eventually eliminate debilitating pain on the face around the eye. So if we now go to the treatment options, so this is Western school of somatic rehabilitation and medical massage. There is very powerful techniques and modalities which developed in different countries by the physicians and scientists in the 20th century. And there is in somatic rehabilitation, there is a lot of complete nonsense in the form of personal opinions. But what the difference between those personal opinions and what you see on your screen? The difference is that each modality which presented here were independently tested by someone that were published in the medical literature with the proof that treatment is better than placebo effect. Rest of the very fancy name techniques which dominate, unfortunately, somatic rehabilitation very frequently doesn't have this feature. There is no supporting material from independent sources. Now, for example, if the therapist or health practitioner is using neuromuscular therapy only, that also is not enough, because that somatic rehabilitation rely on the fact that these techniques addressing specific levels and layers of the soft tissue. Therapist has to have enough expertise to choose from that what actually fit the patient clinical picture after layer by layer evaluation, and each technique delivered on layer basis, and that gives stability of the clinical result. I work with 15, 18 patients per day with the most complicated somatic pain and dysfunction. We have patients who refer to our clinic by Mayo Clinic, by Barron Neurological Institute, and we publish clinical cases in Journal of Massage Science. But I would like you to share with you what our former students do. This is our one student from Arizona, and that's what her patient from 2019 to 2024 who had severe lower back pain with peripheral neuropathy, and she was able to walk only 100 feet before she sit on the wheelchair. As you can see here, she went through everything which is known in the modern medicine to relieve her symptoms with no clinical outcome. Christy was correct by examining her tissue layer by layer, restore mobility between the layers, and then completely eliminate clinical picture, and she is pain-free for almost 2 years. But here is the picture before and after therapy. Look at the amount of pressure built up with the soft tissue. This is last rib. And she actually pulled tissue down to show you how deep crease is. That's insertion of the fascia and lower back muscle in the last rib. And you see it as the very deep adhesions. And that's the same area after she decompress tissue layer by layer and restore proper function. Here is our another student from Illinois. And according to a patient cardiologist and cardiac surgeon, he actually pulled her from the grave. Because as a result of very unfortunate event, she developed heart attack, and then infection was got in her heart during stent placement. And many surgeries tried to control that, eventually create complete failure of her heart, and she had heart transplant. But what actually happened as a result of surgeries, you see her chest right here. And only what separates her failing heart transplant from the outside is the scar tissue, because she completely lost breastbone. So there is no stabilization, the clavicle in the complete luxation, and she cannot do any physical activity. And that's why her cardiac output dropped from ejection fraction, dropped from 60, 70% to 30. And she was left in her apartment to die. She's like 45 years old woman. And all of that happened because she cannot put any pressure on the heart, and the heart transplant fails. So for a year, Mike worked with her, and we direct him what to do, and he was able to decompress scar tissue, stabilize the clavicle, and now patient come back partly to work, and she is not dead. So this is what we and my colleagues try to do, and help therapists to achieve stable clinical result and upgrade their performances. This is what I prepare for you, that information which you may consider to join us or explore more. We have incredible Journal of Massage Science, which is international publication, and we have physician therapists from around the world, which contributing absolutely amazing clinical cases and scientific articles, as well as different sources from them, which we prepare for our students and for the other therapists as well. So thank you for listening.